Morning, everyone. Today, the topic given to me is liver cancer in the era of obesity epidemic. So, since it was more of a clinical topic, I have tried to cover it via public health perspective. So, first coming to NAFLD-related HCC pathophysiology, natural history of NAFLD-related HCC, the data for reported incidences are from various references published in Hepatology International. Healthy liver to steatosis, zero point 0.4 to 0.8 per 1,000 person years, and then a reversible stage till here, 1.2 to 5.29 per 1,000 person years to NASH, and then non-cirrhotic liver and cirrhotic liver with various contributing factors, increasing age, because we are talking non-cirrhotic liver here, so with increasing age, increased size, more male dominant, and late presentation. Coming to the global prevalence of overweight, this data is from the IHME Global Burden Disease Study, global prevalence of overweight in more than 20 years of age group, and it depicts the global prevalence rates of overweight and obesity in 2019 for men and women over 20 years of age group. And in 2019, if we see, the prevalence of overweight was slightly lower in young females than in young males between the age group of 20 to 44 years. And this trend was inverted among the age group over 45 years here, probably because of the menopause in women. And the prevalence of obesity is generally higher in women than in men of any age. And both overweight and obesity's prevalence increased with age and reached their highest point between 50 and 65 years and showed a slight downward trend afterwards. So that was prevalence of overweight. This is global prevalence of obesity. Again, the GBD data. Then again, the pink line depicts the prevalence in females, which is higher than males across all age groups. Then this is the age standardized prevalence of obesity. It increased from 4.6 here in 1980 to around 14% in 2019. And half of this rise occurred in 22 years between 1980 and 2002, and another half after 2002 to 2019. And a constant predominance of women in the prevalence rates of obesity compared to men was observed. Then this is again the data from GBD for age standardized prevalence of obesity in adults, geography wise. So the countries with highest prevalence range were US, Mexico, and Colombia had the lowest prevalence rate of obesity. And in parallel, the prevalence rate of obesity in the Southeast Asian region, depicted by the yellow, started from the same level as the Western Pacific, 0.9 in 1980, and increased, reaching to approximately 8% in 2019. So these are the obesity trends, particularly in India. If we compare the National Family Health Survey data, NFHS 4 to NFHS 5 recently, 37% to 44%, the overall increase is there. And there is a significant urban and rural divide. And among older adults, females have 32% prevalence than males at 21.4%. If we talk the region-wise distribution, the higher rates of obesity are in the north, northeast, west, and south. And the central and eastern states show lower obesity prevalence as compared to the red ones. And if we compare the obesity types, then abdominal obesity approximately 40% as compared to generalized obesity 29%. And India's obesity rate is 11%, closer to higher middle income countries than lower middle income countries. Then coming to the India childhood obesity trends. So this data is based on the World Obesity Atlas estimates of 2020. There are 33 million children in India who are living with overweight and obesity. And these numbers are projected to reach approximately 83 million with 24% prevalence here, and observing 6.2% annual growth in this 15 years. So now connecting obesity to NAFLD or MAFLD, This unhealthy, calorie-dense, fiber-poor diet here, this is the gut lining, leads to gut microbiota dysbiosis, which results in increased short-chain fatty acid and gut hormones. And all these products, gut bacteria and bacterial products like lipopolysaccharides, can gain access to the liver via portal circulation. And there are various pro-inflammatory pathways that are activated. And then parallelly, there is this platelet activation that results in release of platelet-derived growth factors and cytokines and chemokines that promote these Kupffer cells activation and angiogenesis, further increasing the risk of HCC. So, global NAFLD prevalence, globally the prevalence of NAFLD has been estimated at 30%, increasing from 25% in the 90s to 38.2% in the recent times. And if we see the proportion of HCC attributable to NAFLD, it has been found, if you see this, the darkest area, the highest in UK, India, Germany, and Middle East. So coming to the shift in the etiology now for HCC, advancements in the prevention and treatment of HBV and direct antiviral agents for HCC have, we see, reduced the viral associated HCC with a considerable shift to MFLD or NAFLD as an etiology for HCC. So mast cell is now a predominant cause of HCC even in patient without cirrhosis. And in 2022, liver cancer represented the 6th most common cancer worldwide, with the incidence of approximately 9 lakh new cases, and was ranked 3rd in terms of mortality, only behind lung and colorectal cancer. So the pathophysiological mechanisms of HCC, particularly in fatty liver, are divided into these 7: genetic variations, metabolic disorders, inflammatory responses, lipid metabolism and oxidative stress, fibrosis and cirrhosis, molecular signaling pathways, and gut microbiome. And this has been adapted from a study published in Metabolism. So coming one by one to these points, first is genetic variation. So as we know, the mutations in genes such as PNPLA3 and TM6SF2, GCKR and MBO87 heighten the likelihood of developing MASH and HCC. And these genetic variations significantly increase the risk of cirrhosis and HCC, highlighting a genetic predisposition and disease progression. Then metabolic disorders. Metabolic disorders encompasses the insulin resistance, obesity, and type 2 diabetes, influencing liver disease progression. And metabolic dysfunction directly contribute to development of mast cell MASH related HCC, emphasizing the importance of systemic metabolic health. Third is inflammatory and immune responses. Sustained inflammatory responses, as we saw in the pathophysiology, fuel the hepatocyte injury and promote oncogenesis. And altered immune responses in MASH-related HCC amplify fibrogenesis and tumor progression. Next is a lipid metabolism and oxidative stress. The imbalance in lipid uptake, synthesis, and oxidative exacerbates hepatocyte stress, and reactive oxygen species-induced DNA damage and contribute to tumor initiation in MAFLD patients. Then fibrosis and cirrhosis. Progressive fibrotic remodeling enhances HCC susceptibility in MAFLD patients, and MAFLD can lead to HCC even in the absence of advanced fibrosis. So there is a HCC risk even without fibrosis in MAFLD patients. Molecular pathways and microbiome. So there are certain molecular signaling pathways which activate and promote hepatic oncogenesis. And as we saw, the gut microbiome dysbiosis and gut liver axis alterations trigger inflammation and tumorigenesis. Then gut microbiome, the gut liver axis and microbial imbalance contribute to MAFLD to HCC progression, as it increases intestinal permeability, endotoxin translocation, promoting hepatic inflammation and carcinogenesis. These are the only clinical practice update screening and surveillance for HCC that I could find on NAFLD. So this paper gives 8 best practice advice for screening of HCC in NAFLD patients particularly. So first is that screening for HCC should be considered in all patients with cirrhosis due to NAFLD. Incidence rate of HCC in NAFLD cirrhosis is estimated to be more than 1.5% per year, and therefore screening for HCC in this group, NAFLD cirrhosis, is justifiable, but based on cost-effective considerations. And screening benefit applies to compensated cirrhosis or decompensated cirrhosis awaiting transplant. Second best practice advice is to consider HCC screening with evidence of advanced fibrosis or cirrhosis from non-invasive test. So these are 3 categories of non-invasive test. If 2 or more, if the point of care test 2 or more, combine at least 2 non-invasive modalities from these categories, different categories, then it qualifies for HCC screening. And there are suggestive cutoffs for FibroScan and MRE for non-invasive detection of cirrhosis for purpose of HCC screening. So combine at least 2 non-invasive testing modalities from across the groups for optimal assessment. Then third practice advice is patients with NAFLD without advanced fibrosis should not routinely be screened for HCC, as HCC risk in NAFLD without cirrhosis is less than 1%, and systematic HCC screening they have not recommended in early disease, although there is a high risk of developing HCC in early stages of NAFLD than people without NAFLD, but the incidence rate and determinants of risk have not been well quantified, and they were probably too low to justify routine screening at this point. So who should be screened for HCC in NAFLD? All patients with cirrhosis due to NAFLD, NAFLD patients with evidence of advanced fibrosis by non-invasive markers, and patients with combined positive results from 2 non-invasive test modalities across 3 groups. And who they have not recommended for screening is NAFLD patients without advanced fibrosis and NAFLD with early stage fibrosis. So best practice advice 4 and 5 is that ultrasound quality determines screening modality, and when the quality of ultrasound is suboptimal for screening, the further screening should be performed by either CT MRI or with or without alpha fetoprotein every 6 months. Advice 6 is to counsel patients with NAFLD cirrhosis to abstain from alcohol and tobacco, as there is evidence supporting increased NFLD fibrosis, increased risk, and lower HCC survival rates with these issues. Best practice advice 7 is optimal management of the comorbidities, diabetes and dyslipidemia, and through lifestyle modification and pharmacotherapy. So type 2 diabetes has shown increased HCC risk with hazard ratio of about 5. Also, the risk increases with increased type 2 diabetes duration, and metformin is associated with reduced HCC incidence, as sulfonylureas and insulin associated with increased HCC. Statins with decreased HCC, and benefits of statin therapy outweighs risk in NAFLD patients with dyslipidemia. So the last best practice advice is optimal management of obesity through lifestyle modification, pharmacotherapy or endoscopic or bariatric procedures. And weight loss interventions are strongly recommended. Hypocaloric diet, bariatric surgery associated with NASH resolution in up to 85% of patients. So this is a summary of HCC screening recommendations in NAFLD as per this gastroenterology paper. NAFLD with cirrhosis screen for HCC. NAFLD with advanced fibrosis by NITs consider screening for HCC. NAFLD without advanced fibrosis, routine screening not recommended. And obese patients with inadequate ultrasound use CT, MRI for screening. Next is the WHO, the ILBS data. So we published this study in Hepatology International. This was data from for WHOCC from January 2017 till August 2022 from hospital-based record of 11 participating centers across India. And surprisingly, NAFLD was second only to diabetes as an etiology for HCC. So diabetes contributed to 40% of HCC cases, and NAFLD 36%. And after that, hepatitis B 21% and Hep C 18%, and alcohol even down the line from this. And the odds of non-cirrhotic patients having NFLD was 2.117, when adjusted for age, gender, and the presence of hepatitis B, C, and harmful alcohol consumption. Those with NAFLD were 1.553 times more prone to develop non-cirrhotic HCC. So this large multicentric data study demonstrated that NAFLD is the most important risk factor for the development of both cirrhotic and non-cirrhotic HCC in India, and has overtaken viral hepatitis. So awareness campaigns and large-scale screening are required to reduce the burden of NAFLD-related HCC. So there are various policy initiatives of ILBS for primary and secondary prevention of NAFLD, for early reversal of a NAFLD, for to prevent it from converting to HCC. So last year the guidelines were updated and released for NAFLD at the Ministry Nirman Bhavan, along with the training module to train the frontline workers, medical officers, and the medical officers at CHC and district hospitals for early identification, timely referral, and early mitigation for this. And ILBS has so far supported 7 states since 2023, since the first time the guidelines were released in 21, for implementation of these guidelines. So all these states have been supported by ILBS. Another policy initiative is the launch, the first expert consultation on National Fatty Liver Reduction Initiative here. It aims to establish a comprehensive, multifaceted approach to combat the prevalence of fatty liver and mitigate its far-reaching impacts like HCC on the country's health and economic landscape. Thank you.